So hi everyone, thank you for joining us today. My name is Zoe Clark. I'm Senior Self-Management Programme Officer here at NASS. I'm also a healthcare professional and I have AS myself as well. And today we're joined by a familiar face. I'm delighted to have Colin Beevor joining us again. Colin is Matron and Senior Clinical Nurse Specialist at Portsmouth Hospital. Hi Colin, how are you?
Good afternoon everyone. Thank you for joining us in this nice warm day.
Yeah, I wonder if we'll have people out in the garden watching. Slightly jealous if you are. Hopefully everyone's getting a chance to enjoy the sunshine. So if you are, do let us know if you're joining us live. Do say hi in the comments, let us know where you're watching from. So previously we've had a session, Colin's led a session all about biologic medications. So they're the medications which regulate your immune system. So today Colin's going to be talking all about other medications that can be useful for people with axial SpA, separate to the biologic therapies. I will pop the link to the biologic therapy recording in the video description. So if you find after the session you'd like to get a bit more info about those, then we know where to head afterwards. And yeah, I mean, Colin, do you want to introduce yourself to everyone if they haven't seen one of your previous sessions?
Yes, thank you for inviting me. My name's Colin Beevor. I work down in Portsmouth. I'm a matron, so I'm responsible for the clinical services that I run. I'm also a service manager, so I'm not only responsible for the clinical services, I'm responsible for all the budgets and the expenditure from the service and all how we provide the care. But I also am quite lucky in that I still do run my own nurse-led clinics. Not so much AS clinics anymore, but I do see AS patients in my general clinics working with the consultant.
So you keep yourself nice and busy then.
Nice full-time job.
Yeah. Oh, wonderful. And hi to Isabel, who's watching, joining us from the garden in West Sussex. Wow, very nice. Yeah.
Very jealous.
Yeah. Hopefully you can get out on your lunch break, get a little bit of vitamin D. Wonderful. So what we'll do today is I'll hand over to Colin in a minute to go through some slides and do a presentation on the medications that can be helpful for people with axial SpA. And then we'll come back afterwards and have a Q&A. So if you have any questions as Colin's chatting, do pop them in the comments and we'll answer as many as we can. And you can also catch the video on catch-up. So if you can't join the full session, do come back later either to our Facebook page, or we'll also put the recording on our YouTube page and on our webpage, My AS My Life, where we'll also pop the slides from the presentation as well, so you can have a read through at your leisure. So I think that's covered everything. Be happy for me to hand over to you, Colin?
Very happy.
Okay, brilliant. I want to say a quick hi to Anya as well, who's joining us from Colchester. She said she loves your sessions, Colin.
Thank you.
Lovely, I'll see you shortly.
So we'll just wait for, hopefully you can start to see my slides. Can you, can you see them?
Yeah, that's perfect, thanks.
Okay, so thank you very once again, Zoe, for asking me to talk. I enjoy these sessions very much. I would rather be in face-to-face with people because I find that much easier to go through things, but I'm learning to do more through the virtual world. And I understand that's a lot easier for lots of patients because you can watch these at any other time. So I'm going to take you through some other medicines management in axial SpA. If there are questions that come up in the question box that I cannot answer because I don't profess to know everything, and you may have some unusual questions, I will always try and find the answers and feedback to Zoe. So don't worry if there are questions that you ask that I don't necessarily can't answer today, because we will come, or I will come back to you with the answers at a later date, hopefully. So this has been a picture of the management of axial SpA for many years, or the old Ankylosing Spondylitis as it was. And realistically, this is a good diagram of how we should approach the care for people with axial SpA conditions. So with traditional things like the exercise programs, education, rehabilitation, support groups are a key stone, and we're really lucky that NASS have developed so many resources over many years to really support our patient population. But in the cornerstone of your treatment, really, most of you will have started on the basic non-steroidal anti-inflammatories, plus or minus maybe painkillers. And depending on how active your disease is and type of disease you are presenting with, you may then be escalated through a number of other treatments. This diagram really talks about sulfasalazine as a cornerstone for peripheral disease, and I'll talk about that a bit later on. Local corticosteroids, which I'm not going to cover today because steroids are a subject probably on its own. And then, as we've done in a previous session, talk through the anti-TNF blockers and the new treatments that are available. And then alongside the treatments, depending on how active your disease is and how long you've had your disease and how much damage it may have not done, then once again there'd be analgesia. And then for those of you who've got significant disease which has caused disruption to certain joints, you may have required surgery. But realistically today we're going to be talking about the painkillers, non-steroidals, and then some of the other treatments that are available. And as I said, this is kind of the area that I'm going to cover, but I'm always happy to take other questions if you've got them as well. So the treatment of axial SpA should be tailored to the individual, and we shouldn't just be treating a diagnosis. We should be looking at the features and manifestation of the disease in the individual and then deciding on the treatments that fit that category. Now, there are research evidence-based drugs that would direct us to certain drugs that would offer better or improvement in symptoms for patients, depending on if it's predominantly an axial disease, so affecting the spine, neck, and pelvis, through to if it's including other things such as peripheral arthritis, so if you've got arthritis that affects your knees, hips, shoulders, elbows, hands. Whether you've got an enthesitis type disease whereby you've got inflammation in the sites around the body whereby ligaments and that touch the bone. Whether you've got other articular symptoms such as inflammatory skin disease, psoriasis, eye disease, the iritis, uveitis, bowel disease such as Crohn's and colitis, and maybe depending on other long-term comorbidities that you may have. So it's not just about treating the AS, it's about treating all these other features. And of course, the treatments need to be targeted at the level of the symptoms that you may be experiencing at the time. So is there evidence of disease activity or possible inflammation? How much pain is the patient experiencing? How much functional disability that's being caused by the disease? And are there any structural damages such as hip involvement and spinal deformities? We always have to take into consideration the individual's age, because some of the treatments are perhaps a bit more contraindicated in the older population of patients. There are some treatments that we may not want to use in men or women, depending on their age as well. So if you're a young female or male and you've got peripheral joint disease and maybe of an overlapping inflammatory bowel disease, we may not want to be using something like methotrexate, which has some good evidence in that disease, because if you're thinking about having a family. But also the other comorbidities, so things such as asthma sometimes restricts the amount of non-steroidals we can use, or if you've had previous gastric ulceration or problems with swallowing, we may be cautious about some of the other medications. And we also have to take into context other treatments that you may be having for other diseases. So it's not, once again, as I said, talking about one disease, it's talking about that holistic approach to the patient. And of course, there will be patients out there that have in their mindset already what treatments they do and don't want to have. There are a number of patients who are very cautious, especially in this time of COVID, of taking medications that may suppress the immune system in one way or another. So we have to take those wishes on board and try and tailor the treatments so we can continue to improve quality of life. Within this, it does require us to have this, what we call shared decision making. Now, this is a tool that is designed for healthcare professionals, but you can turn it on its head and talk about what the patient's participation is. So the biggest thing is that step one is to engage with the patient to ensure that we're communicating the best information we can to the patient about the treatments that are available for them and the options they have. We may want to explore with the patient, or the patient may want to explore with the healthcare professionals, other treatment options out there. So if there is a treatment option that the patient has concerns around, the healthcare professional needs to discuss other options that may be available. we need to take into account things that are important to you. So if you have specific things that are important to you, if this is a time when you're having the consultations, to talk to the clinician about what the treatments and how they may affect your life or what will improve your quality of your life. The best way forward, and it always is this shared decision is about that the clinician and the patient comes together with the same idea about the best treatments going forward, rather than it coming from the clinician. Now, I do appreciate many patients, because you won't have been down this road before of knowing what treatment's best for you, you may actually always ask the clinician, what would they choose? It is a hard decision because not many of us have ankylosing spondylitis, AXPAR, so therefore we can't really put ourselves in the same position as you, but we will always give you a fair and honest opinion about the medication. There is also a time where you do not need to make that decision necessarily today. You may want to go and research, and I would always encourage you to research reputable web pages. So the NASS web page, maybe arthritis versus arthritis, but rather than going to my experience of a medication, because often people will put up things that are misleading or have incorrect information and may worry you. So always go to a reputable site. Be reassured, charities and organisations such as NASS, when they design their information, whilst they will be asking the healthcare professionals for their input, they are also seeking their membership opinions to ensure that the information is well and truly fair balanced. And once you've made that decision with the clinician, it's about the next steps and what you need to be aware of, and that decision and addressing any concerns that may be affecting your decision. So if we haven't given you the full information, then trying to either direct you in the way to get that information or support you with your decision. So it's not necessarily something that can be done in one clinic, but of course you're often put in a position at the end of the clinic, right, I'd like to prescribe you this, and then suddenly you've got a prescription and you're walking out of the door perhaps, and therefore you haven't had that time. But always think, okay, if I can't have that longer conversation today, I'm going to go away, think about it, and I may ask for a further review. I may use something like perhaps the helplines, or may even write to my clinician just saying concerns. And I think that's key, that if you've got concerns before you start taking treatment, you've had all those concerns addressed. And this is all part of this full patient-centered care. There is no point in a healthcare professional designing or deciding what treatments are the best thing for you as an individual if we haven't taken into that everything that's important to you. So what's important to you as an individual, what's important to you as a family member, what's important to you as a worker, and what's important to you to make sure you've got both not just your physical comfort, but also your mental health and well-being. So that's important when we're addressing concerns and starting treatments, that we need to look at those. And a key one, and I don't know how many of you are getting asked this question now, is what is your goal from the treatment? So if we do start you on the treatment, what do you aim to see? What do you want out of that treatment? Is it you want to just be able to get out of bed pain-free? Is it that you want to be able to work full-time, or you want to be able to do your hobbies and leisures, be participant in your family? They're all key things that will allow us to help decide where we go with your treatment options. And I will always remind you, and hopefully some of you may have been to my previous talks, whereby medicines are a part of your care, but they are not the whole part of your care. So whilst we will be giving you medicines to treat some of the symptoms that you may be experiencing, or the inflammation you're experiencing, there are other things that will enhance your treatments, that may give you better outcomes from the treatments we're prescribing, and also give you and maintain a quality of life. So always think about that whilst we may be giving you a tablet to control your Axial SpA, other things that will always help you are things like the exercise, your mental health and well-being, range of movement in joints and things like that. So there's a lot more to just than having a disease and needing medicines. It's about having perhaps a disease such as AXPAR, using the medicines, but also using this supportive management. And I know Zoe's been very proactive in getting a number of options. So if you want to know about Tai Chi, Pilates, and all those sorts of things, those sorts of sessions are coming up, which will also add in and improve the quality of your life. So benefits of shared decision making is also important. We know that if it's just a prescription that a patient has to cash in, sometimes those medications stay on the shelf because the patient may have not under full understanding. So we want to make sure that you've been fully informed, not only about your disease, but also the medications. We want to make sure that we've alleviated any anxieties around side effects and the day-to-day long-term effects of these medications. Now, most of the medications we'll be talking about today have been around for some time, so we really know the side effects and the things that patients experience. Maybe some of the newer treatments, especially in the biologics and the immunosuppressant treatments that are now coming to the market, we don't have so much information. We are reassured by clinical studies, but we're not always reassured because we haven't had that day-to-day clinical practice. We want to encourage and support patients in the self-management. So we've talked about this in flare management and things before. That actually, once again, medications may be a part of self-management, but they're not the whole part. It's about living in a healthy and lifestyle, and also, as we've talked in the past, about mental health. Patient expectations are a hard thing because, once again, most people want a medication that will take all their symptoms away or their disease activity away. We can't really always ensure that, but we need to understand what your expectations are about medication and actually give you the information that gives you a realistic approach. We know some of the medications, especially things such as sulfasalazine, do not actually work maybe for 12 weeks at the earliest times that they would start to work. So we've got to manage your expectations in those first 12 weeks. How are we going to manage your SpA during those early stages of treatment? We, of course, want you to have good patient experience and satisfaction, but also having that confidence in the clinician you're working with. If the confidence in the clinician breaks down, it's a very difficult road to engage with the patient, whereby they don't have the trust or confidence in their clinician or their clinical teams. And our treatments are always about improving outcomes. There is definitely an aim, and we shouldn't be recommending treatments that cause harm. So the first point is always do no harm, but also is actually do good. So we want to ensure that the treatments we're giving you give you good patient outcomes as well. We're going to talk about non-steroidals, and these are, as I said in the one of the first slides, these are the things that most patients when they're newly diagnosed with axial SpA may be offered. There are a whole host of them out there. Some are in favour and some are out of favour, and some have more evidence in certain disease maybe, and so certain comorbidity concerns if you're taking some treatments. In general, ibuprofen is an over-the-counter prescribed medication or prescribed medication, therefore this is freely available from chemists and maybe even supermarkets. Moving through to naproxen, diclofenac and these other medications, these tend to be are only prescribable in the UK. There are some countries outside the UK that you can buy them over the counter, but in the UK, most of these are only prescribed through a prescription treatment. I must say we very rarely use high-dose aspirin as an anti-inflammatory these days, but they're up because there's a whole host of other medications out there. So when you look at an anti-inflammatory, what are the risks and benefits? And it's always about understanding this scale of what are the benefits you're going to get if you take this medication, but also what are the risks associated with it. So non-steroidals have been around for some time. They tend to work very quick. So if you take them, they tend to work quite quickly within a few hours, and you can sustain a response throughout the 24-hour period. The sometimes, if you've got a lot of inflammation, the actual swelling and warmth in the joints or in the bones may take a little longer to settle down, and therefore you may need to take them on a regular basis for a period of time to actually gain the full benefit. And that allows you to once again maintain your mobility and generally get on with day-to-day quality of life issues such as family, work and hobbies. But they do come with risks and side effects. Most of the non-steroidals, hopefully everyone is taking it with food. They should never be taken without food, as they can cause gastric irritation, stomach upsets, heartburn, indigestion. Some of the other side effects that people may experience are such things as rashes, headaches, patients who have a sensitivity to non-steroidals, such as some of the asthmatics, may notice they have a wheeze or shortness of breath. For some of the older populations, because they can affect the kidney function, you may find that you're retaining fluid and you notice fluid retention, especially in your lower legs. They are associated to, unfortunately, long-term use without stomach protection to gastric bleed. So they can erode the gastric lining of the stomach, which can then cause problems. And also you may find patients who are needing warfarin, which is an anticoagulant, may be asked to restrict their non-steroidals, because if you've got a medication that can cause gastric irritation and the ulcers, and then you've got someone on an anticoagulant such as warfarin, then you're putting their life at risk. So there is risks and benefits that have to be taken into consideration. Non-steroidals have been associated with cardiovascular events such as heart attacks and other vascular problems. And often some people may be not appropriate to use them long term because of their current or previous cardiovascular risks. So it's always worth looking at understanding what is your cardiovascular risk, because it may be that something else you can do will help to reduce your cardiovascular risk. So such things as stopping smoking, which will help, which may then allow you to perhaps be able to take your non-steroidal. There are cautions, as I said, in patients with asthma because of the sensitivity, but also we have to be careful in patients who are drinking more than the national recommended 14 units of alcohol per week. And that's not a binge drink, so it's not 14 units of alcohol in one day. That's those 14 units of alcohol spread over a 7-day period, because these can also cause irritation of the gastric system. If you've got known kidney impairment, your renal physician may be very cautious about using a non-steroidal because of the impairment and the effects that the non-steroidals can have on the kidneys. And we do have to be careful if you are taking non-steroidals and steroids, because both these can irritate the stomach and put you more at risk of gastric bleeds. I would always suggest, if you are experiencing any gastric irritation, even on ibuprofen, that you discuss that with your GP, because you may need something such as omeprazole, lansoprazole, to be taken at the same time to help prevent any complications associated to irritation in the system. And also, if patients have got some form of heart failure or hypertension that may be associated to the non-steroidals, then your cardiologist or your heart physician or your GP may be cautious about taking non-steroidals. But one of the things we know about non-steroidals, if you don't take it, then you are more stiff, more painful. If you're more stiff and more painful, you're not so active, which can also increase your cardiovascular risk as well. So it is that risk and balance that we always have to have a conversation with you. There are a number of resources which are available to support patients in making those decisions. I would always direct people to the NICE document around prescribing and non-steroidals, but also you've got the NHS webpage, which has information about non-steroidals, and also NASS have some information on their webpage. So non-steroidals and NICE, one of the keyest things that they mention about is that a non-steroidal should be used at the lowest effective dose and for the shortest period of time. So many of you may be on long-term non-steroidals, but for the newer diagnosed ones who may have got early disease, you may only need them as you identify this flare. So the diagram below is perhaps you're running along quite well, you're starting to get a bit more achy, and you think you're going to start moving into a flare. So you would want to start to take your non-steroidals if you've not been taking them on a regular basis. So at the point where you're in a significant flare, you would continue to take your non-steroidals and painkillers at the maximum dose prescribed. Never exceed those doses, because they will always be contributing to side effects. But always, once again, look at those self-management tips. So are you still doing a range of movement exercises, stretches? Are you looking at how you're managing the flare from both a physical point of view and also a mental health and well-being point of view? But hopefully, once your flare starts to subside, then you can either start to reduce your non-steroidal painkiller. If it's more pain and stiffness, then you would want to be taking your non-steroidal. If it's just pain, you may want to reduce your non-steroidal and continue to take your painkillers. And you can play around with that level of taking that medication, once again, as long as you're not taking more than the maximum dose. But once again, once you're stable, you may then be able to stop or completely stop or just completely reduce the non-steroidals that you're taking. Taking them, so if you're more painful in the morning, you may want to take a longer acting one in the evening, so it's worked for you in the morning, or if you're more painful in the evening, you may want to take it in the morning so it sees you through as you come back home or once you've done things. So have that conversation with your clinician about how to use your medication effectively. But also, as I said, the key thing is not to exceed your dose. We have seen in the local area where someone has not only taken their perhaps naproxen, they've also been taking their ibuprofen. So in fact, they're getting a double dose of an anti-inflammatory, which could be once again serious. So always, if you are taking other medications and you're not sure if they're in the same class, or are they the same kind of non-steroidal, have that conversation with a healthcare professional or a pharmacist so they can reassure you whether you could take the medication you're considering buying over the counter in addition to your other medications that you're currently taking. And once again, the key thing is around the flu type season, where people may be taking some of the flu remedies. Some of those contain some kind of painkiller as well as maybe a mild anti-inflammatory. And you just need to be reassured that you can take them if you are taking other medication. So whether you should use a topical or an oral steroid, a non-steroidal, my rule of thumb really is if you've got multiple joints, so you've got more than perhaps one or two joints that are painful and stiff, then perhaps the oral non-steroidals are better. Of course, if you've got skin sensitivity or psoriasis, you may not be able to use a topical non-steroidal on a joint area if their skin above that is broken. So that may lead people to actually still needing to take their oral. However, if you've got a single joint, you may find something like a topical non-steroidal cream more effective. There are some cautions, once again, still around gastric irritation in patients who use the topical. So once again, have that conversation with a pharmacist. If you're unable to use a non-steroidal, and I previously may have talked about this in other talks, there is a cream around called Capsaicin. It's a derivative of the chili pepper and has got an indication and license for osteoarthritic pain and local neuropathic pain, where we want to avoid other treatments, or you can't tolerate other treatments such as non-steroidal. So that's something that you could have a conversation with your GP or your healthcare professional. Of course, if you're older, you may have got a bit of osteoarthritis on top of your ankylosing spondylitis or SpA, and so therefore it may be indicated. Some clinicians are a bit more cautious about prescribing what we call off-license. So there is no evidence of osteoarthritis and they're prescribing it for the SpA single joint pain, then they may not be keen to do that because it's what's called as off-license prescribing. In general, it has limited side effects. You use a small piece of cream size of a pea size on an area, and you use it 3 to 4 times a day. You do have to use it on a regular basis for a period of time to get the best benefit out of it. You shouldn't use it more than 4 times every 4 hours. And I would always suggest people to try a very small patch of the cream on their skin just to make sure it's not going to irritate that. As with the non-steroidals, you can't use it on psoriatic arthritis plaques or any open wounds. The other thing is, because it is it's from the chili pepper, don't get it near your eyes. And I always say to my patients, don't get it anywhere naughty because it will sting. So when you go into the toilet, make sure you wash your hands effectively, because the last thing that you want to do is put some residue of the cream from your hands on your genitalia. And it's worthwhile reviewing that treatment after about 8 weeks to see if you've seen any benefit. Versus Arthritis have a good section on capsaicin cream on their web page. So moving to painkillers, also known as analgesia, there are kind of 3 levels. They're the routine painkillers, once again, that can be prescribed over the counter, such as paracetamol. And then there are other weaker opioid mixes of the painkillers such as cocodamol and codidromol, depending on the strength, depending on whether then that is prescribed or over the counter. So these are medications are effective. I worked with a famous, or quite a notorious good chronic pain consultant who said that actually paracetamol is an underestimated medication, and if it's used effectively, it can be used with good benefit for patients. So if you're finding you've not tried paracetamol on a regular basis and it's not contraindicated, then you may want to consider adding that in if you're having peaks and troughs in your pain. The cocodamol and codidromol can have other side effects. So most painkillers can cause you to be constipated. Some of the ones with codeine in, some people have allergies to codeine, some people have intolerances. So some people talk about dizziness, brain fog, and I can't take codeine-based medication. It makes me feel really quite unwell. But for those who it works in, it's a good medication. The next level are what we call these weak opioids. They're prescription medications such as tramadol, codeine, codeine phos, and dihydrocodeine. These are effective medication, but they are slightly stronger and maybe than the routine painkillers, but they come with other problems. There may be some addiction concerns around some of these medications. So once again, only ensure you're taking it as advice of your clinician. What we do also see is patients that maybe have got a partner with another form of arthritis, and they start to share their painkillers, and actually that is a rocky road to go down. We would always recommend that you only take medication that is prescribed for yourself rather than a partner, family, friend, or neighbour. Then moving on to opioids such as morphine, oxycodone, fentanyl patches, buprenorphine. These are opiate-based medication, and unfortunately they can lead to addiction. So we do try to restrict these in our patients with musculoskeletal conditions, because you have got a long-term condition. It's not something that's short-lived where perhaps morphine could be given. Say if you've got a kidney stone and you've got a kidney, you're waiting for that kidney stone to pass, maybe using some of the opioids would help. But as soon as once the kidneys pass, the pain is resolved, the patient would stop the treatment. Because you've got this ongoing pain, then it may be you would struggle, you become quite addicted. And we do know that over a period of time, you do have to find that these doses are escalated. So someone may start off on a low dose morphine tablet, but actually not too long, they've escalated to quite a high level. So we would be cautious about maybe opioids in our patient population, trying to look to other treatments. If it's due to disease activity, then it may be that we do need to escalate other treatments rather than the pain medication. So painkillers are the most frequently used to manage pain. They do come with side effects such as drowsiness, nausea for some people, vomiting. They are notorious for constipation. So if you are susceptible to constipation, then you would want to make sure you're using an effective laxative. And what's really funny, if you look on the paracetamol side effects, they can also cause headaches. They can also cause irritation of the skin. Some of the opioids or mild opioids may cause other things such as fast racing heartbeats, confusion, hallucinations, fainting, skin rashes, blurred vision, vomiting of blood, passing blood in the stools, and acute abdominal pain. So they are, if you get those sort of side effects when you're on painkillers, then you need to contact and discuss that with either your GP, or if you're worried, the NHS. Sorry, that should say 111, not 119. The 119 is the COVIDs. I'm so used to typing at the moment, but it should be NHS 111. And also be careful of the amount of alcohol. Once again, no more than 14 units of alcohol per week, and no binge drinking, mainly because most painkillers are detoxified by the liver, and alcohol is also detoxified by the liver, and therefore you may find that your liver function tests become abnormal if you are taking both together. We talked about addictions. It's important that if you feel you are concerned about addiction with your painkillers, that you have that conversation with your GP so they can advise you and support you. So disease-modifying drugs such as sulfasalazine have limited or some evidence in axial SpA. Sulfasalazine has some evidence that we may use, and we do see it being used in maybe patients we can't escalate their treatments to a biologic. And also, some patients may find that we escalate patients to methotrexate or leflunomide if they've got psoriasis, maybe methotrexate if they've got iritis, or methotrexate if they've got inflammatory bowel disease. So it's, once again, looking at a holistic approach to their disease management, not just looking at the axial disease or the peripheral joints. We may need to take into consideration other comorbidities and treat those with effective disease-modifying drugs as well. Just going to briefly mention about herbal medications. Remember that herbal medications are not licensed necessarily, so the same route as prescribed medications. They are often licensed through the food agency, so therefore they may not have followed the same rigorous clinical trials, and often there is not much clinical evidence in the background that supports their use. It's just anecdotal or recommendations. But herbal medications often have active ingredients, often from plants such as leaves, roots, or the flowers. There are many out there for, we know for menopausal symptoms, things like evening primrose has some very good evidence. And you may find that you're actually taking those in combination with other treatments as well. I would always suggest, once again, that you, when starting a herbal medication or starting a new medication, when you're currently taking a herbal medication, that you have that conversation with the pharmacist, just to make sure there is no interaction, because some herbal medications are contraindicated in some diseases, and also have some contraindications with some of the medications that are out there. So remember to have that conversation. You may have a bad reaction to a herbal medication or have side effects. As I said, not all herbal medications are regulated in the same way as other licensed practice, and the evidence for effectiveness of herbal medicine is generally very well limited. There aren't many clinical studies out there, and there are often not clinical studies that look at the medications being used in combination with other treatments. So just about herbal medications, they may be suitable for someone or some people. I would always take on the advice of a healthcare professional, and always make sure that the person who's recommending it, whether it be a herbalist or in a shop, that they understand your condition, some of the other problems that you may be experiencing, and also the medications you're taking. Some have cautions during pregnancy and breastfeeding, and some also have cautions in the elderly. However, I will talk about turmeric. Turmeric has really taken off in the last few years. It's believed to have an anti-inflammatory benefit. It does come with side effects such as headaches, diarrhea, and possibly skin rashes. But it has got some evidence in as an anti-inflammatory, mostly in osteoarthritis patients, but it's something that maybe you want to try. Once again, only have that conversation with maybe a pharmacist. You do have to be aware that it can infect warfarin, so you do need to be aware and have that conversation maybe with your warfarin team or your GP if you wish to take it, because the last thing you want to do is affect your warfarin levels in addition to anything else that you may be experiencing. So now moving on to other pain medications which may supplement your management of your pain. So amitriptyline has been around for some time. It was originally treated to manage anxiety and depression, but at a higher dose than we would normally recommend for managing persistent and chronic pain, which may be associated to damage of your nerves or to poor sleep because of ongoing pain. It works by increasing the amount of serotonin in your brain, and serotonin is a neurotransmitter in the brain that sends out messages to the nerves in the body. We know that serotonin is thought to improve your mood, which once again may improve your experience of pain and your ability to tolerate pain, but also it helps to improve sleep, quality of sleep, which once again may improve that poor sleep cycle, and that sleep cycle, which means poor sleep cycle, more pain, more pain, more fatigue, poor sleep cycle. So it does have that, may help in that vicious circle. The low doses of amitriptyline we often use would not treat depression, but if you have got known depression and your other antidepressants, you may want to have that conversation with your GP or your healthcare professional. But it does seem to improve your pain, relax your muscles, and improve your quality of sleep. So this is the benefits: improve quality of sleep, which can improve experience of pain and quality of life. Side effects are once again constipation. Lots of the antidepressants can cause dizziness, dry mouth. You have to be cautious if you're taking amitriptyline. If you've got a job whereby you need to drive maybe in the morning, or you've got young children or someone you're caring for that you need to be awake for, because it can make you sleepy. It can affect your ability to pass urine, and it can cause headaches. On the line of improving your quality of sleep, often people will take this just before they go to bed, so maybe 9, 10 o'clock. You actually probably need to take it a bit earlier so it starts to work for you. So when you go to bed, it's really helping. Once again, there are a number of side effects that you should consider, and once again, ring NHS 111, not 119, if you're experiencing any of these symptoms. Generally tolerated. We normally start off on maybe 10, 20 milligrams a day at night, but can be increased as needed by your GP. It doesn't work quickly. It does take 1 to 2 weeks before it can kick in, but it can take up to 6 weeks for it to work to give you that full benefit of painkiller. If you're given a higher dose, if you're recommended to start on 20 milligrams and you're getting side effects, maybe ask if your practitioner if you can drop it down to maybe the 10 milligrams. I've had one lady recently who I've advised, she started off on taking 10 milligrams 1 day a week, mostly on a day when she didn't need to worry about being up in the morning or feeling brain fog in the morning, and as able to tolerate it, then she increased up to 7 days a week. And then once again, when she was stable on that dose, she's now taking 20 milligrams 7 days a week. So she's modified her medication. She's been able to tolerate it, and it's starting to give her some benefit. If you're getting side effects from the medication, talk to your GP if you're not wanting to stop it. And as I said, it doesn't really have a lot of use in management of depression these days. It does have that evidence in treating pain. Gabapentin, there are a number of these ones. I'm not going to talk about all the neuropathic type pains, but I'm going to talk about gabapentin. So it was originally used to treat epilepsy, but has also now got a license and used in nerve pain, which can be difficult to manage. And that includes mostly diabetes and shingles, but also from injury and other long-term conditions, which may include ankylosing spondylitis or SpA. It's thought to block the pain that's being experienced by blocking the pain messaging around the body, in the brain, and down into the spine. You do need to take gabapentin usually 3 times a day, and you can take it with or without food, and generally you would increase the dose over a period of time as tolerated. Some people struggle with the tolerating with higher doses. It can make you once again feel sleepy, tired and dizzy, but generally these side effects are mild and go away as you tolerate the medication. It can last for a few weeks for the it can take at least a few weeks for the gabapentin to work, so don't necessarily give up on it quite quickly. Be aware it can be addictive, and that's more in that if you no longer want to take it.
The recording has stopped. This meeting is being recorded.
Zoe, do I need to do anything?
I'm sorry about that. No, my internet just cut out, so it's come back in, so that's fine.
Okay, so be aware that if you are on the gabapentin and you're on the higher doses, you may not be able to just stop it without getting withdrawal symptoms. So you need to have that conversation with a healthcare professional. So generally, if you are going to stop it, as with the increase in dose, you would gradually reduce the dose over a period of time. So side effects are, once again, it can affect the moods. So it can make you feel a bit low in mood, may make you feel euphoric. It can also cause things like dry mouth, as lots of these medications do. For men, it can cause erectile dysfunctioning, or for all of us, it can cause weight gain, memory loss, or memory problems and headaches. So it's not a medication necessary to go into without having the full understanding of what the benefits it may have for you and the indications. And if you've got problems around certain things, if you've already got a dry mouth, the last thing you want to do is take another medication that increases that dryness. Same as if you've got problems with maybe memories and things like that, or weight gain. So they're generally the medications that we use. There are many out there. And we always talk about this pain ladder. So this is about understanding where you are with your pain level at the moment and gradually increasing your medication as needed through this pain ladder. So you may start off on non-opioid basic analgesia with non-steroidals, but you may move into the weaker opioids, stronger opioids for short periods of time, and then go on to other things if you've got significant symptoms. But it's always about not only understanding that you may want to escalate your pain medication, you may want to de-escalate it independent of what you're experiencing. My concern has always been is that if you've got too strong opioids for your condition today, and then you have something else, a life event such as a significant cancer where you may need painkillers, that maybe that you won't get the same benefit from the opioid at that time when you need it for something else. So we do try and withdraw painkillers as able, but understanding that people need to have a quality of life. If you're worried about drug interactions, there are a number of web pages that you can go into. There's the UK BNF NICE organisation, org.com, sorry, org UK interactions webpage, where you can actually search for your drug and look for other interactions that may be registered and known to be a side effect or interaction with the medication. It's a very useful resource. What it is difficult is you sometimes can't add too many medications, so you are probably looking at one or two medications and the interactions with other medications rather than all your you can't put a whole list in and get a list really. And there's also the American one, which is drug.com. I must find that one's probably a bit more friendly, user friendly, but you have to be aware it's a USA based advice, so some of the terminology is from the American terminology. Often people talk about side effects, intolerances and sensitivities to medications and allergic reactions. And it's really important when you are reporting to your healthcare professional that we understand, is this a known side effect? Because if it's constipation on paracetamol, we know it's a side effect. It doesn't need to be necessarily you managing that side effect. Whereas if it's an intolerance that you find not only does it cause you, you can't tolerate medications such as nausea, dizziness and headaches, that's slightly different. And then allergic reactions are even more different. And we often get people say that I'm allergic to something, and actually what we find out is an intolerance or they've had a previous side effect. So allergic reaction is these acute symptoms that normally start within a few minutes of you taking a medication and last a few hours after. Whereas in intolerance, maybe it comes on later on as you'll take the medication and lasts for a few days or weeks afterwards. So be very clear when you're reporting problems with medications that the prescriber or the nurse or whoever knows that is this a true side effect you've been experiencing, is this an intolerance or a sensitivity to the medication, or is it an allergic reaction? So about adverse reactions, I've talked about this in the previous slide. Some are very common. So constipation in paracetamol is very common, and through to some of the rarer ones. So if you want it visually described, so very common is 1 in 10 people would experience a side effect with that medication. If it's common, it's a 1 in 100 people would experience that side effect. If it's uncommon, it may be 1 in 1,000. Rare is 1 in 1,000 to 1 in 10,000. So that's about seeing a shooting star or maybe winning the lottery. So the ratio of risk to side effects is very different depending on what side effects reported. Anaphylaxis, allergic reactions are important to be aware of. These include normally quite a short, after taking the medication, you may get a rash. It includes an itchy, red, swollen, blistering or peeling rash. things like a wheeze in for asthmatics in non-steroidals may be an allergic reaction. Tightness of the chest or the throat and a difficulty to swallow or breathe, and difficulty in inspiration, breathing in and breathing out. You also may find that the mouth and the lips start to swell and the tongue starts to swell. If you get any of those sort of experience any of those when you're taking any new medication, then you need to call 999. This is not normally an NHS 111 or call the GP. You normally do need to seek medical attention through the 998 or 999 or go through to the emergency A&E department. If you are experiencing those, please don't get in a car. We've had instances whereby a family member thought, I'll get you to hospital quickly by putting you in a car. But actually, if you become really unwell in the car, it's very hard because you're on the move. That person who's driving the car has got to find somewhere to park to start to assist you. And then also you may not be able to know where you are. So if you need to call an ambulance. So if you've got significant allergic type reactions, you should always call 999 for support. So this is the last bit, is about what you should ask for when you're starting any new medications to control your pain. So why are you taking that medication? If you don't understand why you're taking that medication, you may not understand the reason and benefits. You may not be compliant or according to taking medication as recommended. Always ask about how you should take it. And often people will walk away from the department and say, oh, I don't know whether I should take this tablet in the morning, in the afternoon, in the evening, how often. And of course, we will often write in terminology such as BD, which is twice a day, QDS, which is 4 times a day, or TDS, which is 3 times a day. Because if that's on your prescription and you don't understand what that terminology means, it's not really, really helpful. You need to know how to store the medication safely, but also to make sure the medication doesn't degrade. Why is this medication important to you in managing your disease? How will you know if it's not working and how long it will take to work? What sort of side effects you may experience? Does it have any effect on other medications that you may be taking, both over-the-counter, prescribed, or herbal? And what happens if you miss a dose? Can you double up? Can you take, not double up? Generally, we wouldn't advise you to double up. But say if it's methotrexate and we talk about it as a weekly tablet, it may be that we wouldn't want you to take it if you miss a dose. We'd rather you miss until you're due to take it again. There have been some safety alerts and methotrexate. It comes in a number of size tablets. It comes in a 2.5 and a 10 milligram tablet. And we've had in our area and nationally patients who have not been aware, and they're suddenly being prescribed with 10 milligram tablets and end up taking 10 10s instead of 10 2.5s. We locally only recommend taking 2.5 milligram tablets. We also recommend you take it on the same day of the week so you remember it. And lots of people have different ways. I use methotrexate Mondays, and because you need this other drug called folic acid to help with some of the side effects, I recommend methotrexate Mondays and folic acid Fridays. So you've got the M for Monday and the F for Fridays. Know your medicines. This is a really difficult thing. The number of times we see people in clinic and they usually say, oh, what medication you're going on, they'll often say one little red one and one little blue one, or one for my heart, one for my, I don't know, my diabetes. But you should really know your medication because it will help us. Don't remember, not all NHS systems are linked together. So we have systems here in Portsmouth that we cannot see what the GPs are prescribing. So we do not, and they do not interact with your hospital records, including that list, any over-the-counter medications, any herbal supplements, but also keep a list of your vaccinations and also keep a list of your known allergies to medications, but also foods, animals, and anything else you may be allergic to. If there are some medicines have an alert card, so we have a local alert card for methotrexate and some of our other medications, I always carry that in your wallet. If you are more forgetful and you need a bit of support, the Lions charity have a thing called Message in the Bottle. They would normally suggest you write a list of medications, also your contacts. You can then have 2 of those bottles. One you would normally put in your fridge, and you have a green label that you put on your front door. So if an ambulance comes to you, they know to go to your fridge to get a list of your medications, your emergency contacts, and also any allergies you may have. You can also put one on your car window and put the bottle in your what do you call it, the under the dash lockable area. So once again, if the ambulance crew come, they see that on your windscreen, they know to look into the glove box to get the bottle out. It's a good also to keep up, you can photocopy the information in the message in a bottle and then put that in your wallet or in your handbag. So you've always got that on you in case of need. Where to get more information? First of all, I'm going to talk about where not to get information. And it is really this Chinese whispers. Someone may start off by saying, as you'll see here, Sam said that his friend had, Sam had said that he'd had a bit of sickness when he took his medication. And by the time it's got to someone else who may be taking that medication, you find that that Sam not only felt sick, he ended up in ITU. And that's been just this Chinese whispers where it's been escalated out of control. So try not to use that sort of advice. Of course, you may want to seek other people, and places like the chat rooms in some of the patient organisations are very good because they are moderated. So someone in the background is making sure that the right information is being put on there rather than someone else's, just my experience of living with a medication. But there are some really good information resources out there. There's lots on the internet. I always advise you to go to reputable sites such as NASS or Versus Arthritis about medication. You want to have that conversation with your GP, your hospital pharmacist, your community pharmacist, or even your GP pharmacist. And also you can use the NHS Medicines Checker webpage, which is really useful if you want to understand more about your medication. There are also what's called the EMC, or the Electronic Medicines Compendium. This is a very good information resource. They have both a healthcare professional section, which will talk about some of the side effects in deep and the risks. But there is also a really useful patient information sheet that's aligned to the information that's being used. If you are having a side effect, if it's not known, then it's important that you report it. The yellow card system is not just there for healthcare professionals to report. Anyone can report a side effect with a medication. So you can go online, put the medication you're currently taking and the side effect you're experiencing. You don't have to do it if you're just getting new side effects. If you're concerned about a side effect and you think it's important for the MHRA to understand, then go on and register that information with them. Just be aware about medicines wastage. We see a lot of patients, or we see a lot of wastage in the NHS. About £3 million worth of medication is wasted every year. There are some key messages around this. Make sure you take medications and let your GP or pharmacist know if you're stopping it so they're not continuing to be prescribed. Don't overstock your medication. So don't necessarily think, oh, I'm panicking that I'm not going to get next supply, so I carry on ordering it on a monthly basis, whether I need it or not. Ask about a medicines review on a regular basis, because it may be you no longer need that medication. If you need to go into hospital, make sure you take that medication with you. So they would use that maybe as the first point and then supply you with medication when you're discharged. But your medication should be only used for you as well. As I said, try not to get into this habit of sharing your medications with others, because there are concerns around that. Just remember that if you do open a medication, it can't be reused, it has to be disposed of, it can't be taken back to a pharmacy and used for someone else. So if you have got medicines to get rid of, take them back to your local pharmacy. You should never wash them down the toilet or sink, because they will go into the sewage system and also into the water recycling. So it's something that can't necessarily be filtered out. Don't use out-of-date medicines. Don't stockpile medicines. These are all key things that people need to be aware of. Other support and information about pain management and pain medication can be found from Action on Pain, British Pain Society, Pain Concern and Pain Support. They've got very useful information. They also have, if you've got, say you've got trigeminal neuralgia, which is a pain in the face, they have some really useful information about how to manage those sorts of problems in addition to generalised managing pain. There's also, if you want to get the best out of your living well with pain and not necessarily go down the medicines route, then talk to your GP about a pain management program. There are lots of benefits from these, and they've got really, really good evidence. So they help not only just so you understand that pain doesn't necessarily mean damage, but it also gives you ways of managing that pain through exercise, relaxing, mindfulness, understanding emotions that we may be experiencing with pain, understanding how others are managing to live with pain in different ways, and also learning to pace yourself to avoid pain flares. So that's my talk. Hopefully you found that useful. I'm happy to take some questions. I know we've got a few minutes left. And as I said, Zoe can share this slide with you and also all these slides with you. And I'm happy, if I can't answer any of the questions today, to come back with the answers through Zoe. So I'll stop sharing now.
Hi Colin, that was fantastic. Thank you so much. That was really information packed. So we have had a few questions through already. For anyone who's watching, if you have any further questions, please do pop them in the comments. We'll try to get through as many as we can in the next few minutes. So the first question we had was from Ayub, who was asking about gabapentin, because he's taken it for a number of years. And he was wondering if it's true. He's heard that if you stop it suddenly, it can kill you. So he was wondering, I think, some reassurance there.
So I think it's more that you can get withdrawals, and that withdrawal may be quite significant. So, I mean, I think the concern is what happens if you suddenly have to come into hospital and someone forgets to take it or give it to you. So it's, once again, that's where something like, I mean, hopefully most of us, if we get an emergency admission to hospital, we're gonna be awake and be able to tell someone. But if you're not, that message in a bottle is a really good idea, because it does alert the healthcare professional to be aware of that. And remember, your A&E departments or even your walk-in centres don't necessarily have access to your full NHS record, so they wouldn't necessarily see it. So as long as you're aware of it, you may want to choose to, if you're that concerned about it, you may want to choose to wear an alert band or use some of the other ways of alerting, medication alerts to any healthcare professional you come in. But there is this, I think the more of the concern is that you have withdrawal from the medication, which may be not nice to go through. So definitely don't stop it abruptly.
That's reassuring, thank you. And the next question we had was in regards to the non-steroidal anti-inflammatory medications. Nathan was asking, so other than omeprazole and taking them with food, were there any other main tips for protecting the gut when you're taking them?
So I think there is once again lots of information, especially if you're a person that suffers from indigestion quite easily. I mean, one of the key things if you're a smoker is to stop smoking, because that can irritate the stomach. So that gives you an additional downside to if you're taking a non-steroidal. If you've got a bit of gastric reflux on the medication, rather than laying flat in bed, maybe sitting up in bed slightly or perching yourself or position yourself so you're slightly more upright in bed, not fully upright, but perhaps with 2 or 3 pillows, that may help. If you can't do that, and if you've ever tried to sleep sitting up, it's not easy, especially if you've got Axial SpA, then it may be difficult on your neck and things like that. The other thing you can do is put bed blocks at the top of your bed, so your top of your bed is raised, but you can still sleep with 1 or 2 pillows, what you would normally do. The NHS webpage has some really good ideas about managing indigestion and gastritis, about tips around that. Try not, if you do suffer from eating less spicy foods, eating little and regular, a small amount of regular and often rather than big meals may also help.
Oh,
I can send you the link to that information as well.
Thank you. Yeah, I can add it to the comments and reply to Nathan's comment with that. Thanks. And just a couple more questions we've had so far. Ayub was also asking about the timing of his itorikoxib. Because he said the doctor recommended to take it in the evening, so then it helps him in the morning, but he finds he's struggling sort of around midday when he's at work. Is there any sort of advice you can give? Obviously, sort of general advice. Best to check.
Because it's a once a daily tablet, that's where the medication people do run into problems. It may be that you need to change to an alternative one where you can take it twice a day. Meloxicam is a tablet you can take once a day at 15 milligrams. You could also take 7.5 milligrams in the morning, 7.5 milligrams in the evening. Look at the timing of the day. So because you need to take the itorikoxib with maybe food, and you may then take it with your evening meal, it may be that you could take it later on, but with something like biscuits, milk, or something like a light snack. So you've got some food in the stomach. So it may be that you may be able to push it along slightly so it gives you longer control. But look, I would have that conversation. If it's not lasting you 24 hours, then you need to be thinking about, is it the best medication, and do you need to change to something else? And I would always say, look at your stretches, because once again, we're very good at getting to maybe at work and then suddenly thinking, oh, it's stopped working by mid-lunchtime, and we've really not done our stretches exercises, which may help not be helping or contributing.
Absolutely, I know I can be guilty of that sometimes. It's easy once you start working, you're focusing on something, you just lose track of time and realise you've not moved for a few hours, and no wonder it's sore.
Yeah.
That's brilliant. And finally, it's not it's a biologic question, but I'm going to sneak this one in there if you don't mind. Nathan was wondering if you know of any news on the JAK inhibitors. That's the tablet form of biologic therapy.
I haven't had any update recently. I know they are still in the early stages of trying to get their NICE approval. I don't know, NASS may be able to give more of an update, because I know you've been party to the NICE consultation. But normally what would happen around 3 months before, as soon as it's NICE approved, we would normally get a notification, and then we have a 3-month window of opportunity to use the treatment before we are what we call, we have to do a NICE report. So I haven't had anything come through to me, so I expect it's still not being approved at the moment, but it's round the corner, hopefully.
Yeah, absolutely. We'll definitely update everyone when we have news across social media and our mailing list as well. I'll put a link to our newsletter sign up in the description as well when we finish. So you can sign up to the newsletter so you get those sorts of things into your inbox. That's brilliant, thank you. So yeah, we've covered everyone's questions so far. If anyone has any last minute questions, do pop them in the comments. But yeah, I'll keep an eye over the next few days for anybody watching on Catch Up. If you want to add any questions, hopefully Colin wouldn't mind me passing them on to him.
No, you can email me and I'll feedback.
That's wonderful, thank you. And yeah, just to let everyone know, so if you've joined us partway through the video, we'll stay on our Facebook page, and we'll also pop it onto our YouTube page and our webpage, My AS My Life, alongside Colin's slides, which is kindly shared with us. So you'll be able to go through and have a read in your own time as well. And our next session is going to be in a couple of weeks on Wednesday, the 6th of July. At 1 PM, we'll be having a therapeutic Tai Chi session with physiotherapist Susie Gatewood. And she did a session previously that was really popular, so we're looking forward to having her back and having another try at Tai Chi. So that's wonderful. We've got some lovely comments coming in. So thank you everyone for joining us, and thank you so much for the time today, Colin. That was really, really valuable for everyone. And yeah, I can see for the number of people watching as well, you all found it really helpful.
Okay, thank you. Enjoy the summer months, everyone.
Absolutely. We'll definitely have you back for your winter wellbeing tips, because they're always really helpful.
If you're at Hampton Court, come and see me at Hampton Court. We have an arthritis garden this year. So I'm in the community allotment section. I'm there on the Monday, Thursday and Friday. So want to come and speak to me, come and drop in and see me at the Hampton Court Garden and Flower Show.
Oh, brilliant. Oh, good luck with that. I hope it's enjoyable, and you hopefully get the sunshine for it as well.
Weather, yeah.
Well, thank you everyone for joining us, and see you all in a couple of weeks. And thanks again, Colin. Take care.
Take care.